undergo surgical treatment. Okay. Next question. What are the factors involved in considering artificial disc replacement versus a fusion? What are the success rates? What about quality of life and outcomes outwards? So basically, outcomes with regards to artificial disc, I don't do them myself, so I will not be able to shed light from my experience, but from the data that has been reviewed, it's a mix. It's mixed results. But I think again, the answer that I gave earlier, if it is a multi-level degenerative process, the outcomes are worse versus the single level. The two incidences where we automatically send patients for instrumentation or decompression are going to be, and there's no two questions about it, if there is a neurological compromise, if there is a foot drop, if there is cauda equina syndrome, if there is a limp that is developing or weakness in the leg, that is a surgical candidate. You don't wait for conservative therapy. You send them to the surgeon. That is exactly the algorithm we use. Now, if it is a big disc and I can reach it with endoscopic approach by getting to the Cambin triangle, I will do it myself. If it is a more central disc, I will send it to the neurospine surgeon. The other indication, which is absolute surgical intervention is needed, the absolute indication is going to be pars defect with listhesis, which is mobile. If it is a chronic listhesis, which has become sclerosed and is not moving on flexion extension X-rays, then conservative therapy can be used. So it's a dynamic algorithm. Depends on the nature of the patient's presentation and imaging results and neurological status. If there are any other questions, please send them forward. I have one question for you. Okay.
And I had one thing on the artificial disc. Yeah, there's one more. On the artificial disc, Dr. Saab is correct. It's a mixed picture, but it's interesting. The company that made the scraper that scrapes off the failed disc, because as I do chronic pain and I deal with failed back, so after they have the fusions, they come, mashallah, I get those, and also the failed disc replacements. And the company that made the scraper after it failed made more money than the company that made the disc replacement. So the artificial disc actually did not make as much as the one that made the scrapers. That tells you how many of these surgeries are failed. And that's why it says that the discs that Allah gave you, try to keep them, because we don't have the technology to make anything near as the good as the one that you were born with.
Okay, there's a question. Is there any effect on the visceral organs with spinal cord stimulation? As we know, there is thoracic and lumbar innervations. Spinal cord stimulation works especially well on extremity pain. We also have used it for headaches previously, but when it comes to visceral organs like some type of abdominal pain, whether it's from radiation for the treatment of cancer, a lot of the chemotherapeutic agents do cause neuropathy as well. We have other procedures for visceral organ pain. When it comes to abdominal pain, we can block certain nerves that lie right in front of the lumbar spine at the L1 area, called the celiac plexus. It starts with just a diagnostic block with local anesthetic, but for patients who are actively dying from an abdominal tumor, we can actually cause long-term relief by the injection of either alcohol or a substance called phenol. I think these are more reasonable and ethical solutions to visceral pain than spinal cord stimulation.
However, recent use of dorsal root ganglion stimulation I have found that apart from extremities, the perineal pain or pelvic pain can be, we can use in some cases successfully the use of dorsal root ganglion stimulation. But again, abdominal pain is difficult to treat, and we have to look at the, first of all, etiology, and if it is cancer, debulking, radiation, and then along with that, ablation of the sympathetics is usually the answer. Does SCS help phantom pain? Yes. Spinal cord, do you want to answer that?
Yes, phantom limb pain. So phantom limb pain is basically pain in a limb that previously was there. So patients who have had, let's just say, a below-the-knee amputation from, either trauma or severe vascular disease, they will come in and complain of a pain where their foot used to be, even though it's not there. This is what's called phantom limb pain, just as a background. Now, there is a thought process that a lot of phantom pain is also called, it's also a type of central pain, specifically in a region of the brain called the thalamus. It's very hard to treat. We typically start first line with medications, specifically some of the antidepressants, specifically tricyclic antidepressants. But when those also have side effects, when those do not work, spinal cord stimulation is a modality we can try to help with phantom limb pain.
So spinal cord stimulator therapy is definitely part of the algorithm, but the data also is very clear on the use of desensitization physical therapy interventions early on have shown good reversal. Patients that have phantom limb pain, there is a mirror therapy where they put the mirror of the opposite limb, and they move the opposite limb, and they imagine that the limb that is missing is actually there, and then doing physical therapy will actually it's the neuroplasticity of our synapses that can actually re-trigger a normalization of the pathological pathways. So physical therapy and desensitization are the first modalities we use and before we go to the spinal cord stimulator therapy. Many times I will use diagnostic injection. If it is the lower limb, lumbar sympathetic block. If it is upper limb, I'll use stellate ganglion block, and that will give me a bit of an insight whether spinal cord stimulator therapy is going to be appropriate for these patients. However, that is not 100% clear. So this is the way we manage these patients, along with oral neuromodulators, as said earlier.
And one other thing also, but after the sympathetic block, which is diagnostic, or the stellate ganglion, sometimes there is some warm radio frequency used at around 60, 65 degrees. So that's before you get to the spinal cord stimulator level. If the sympathetic or the stellate blocks, the stellate ganglion blocks work, but the pain comes back, the warm radio frequency at 65 to 70 Celsius has also been shown to be beneficial for longer-term relief, maybe up to 6 months.
So basically, to sum it up, the neuropathic pain that we're talking about is noise that the nerves are creating that are going past the filter that is in the dorsal horn. Basically, if you were to think of it in that manner, there's restarting of the nervous system that can reorganize the signals, and that's where the blocks will come in. Or if that doesn't work, then neuromodulators, oral neuromodulators such as amitriptyline or those classes of medications are used. But then again, some patients cannot tolerate them. Especially in elderly, be very cautious when using amitriptyline because it has increased risk of falls. Did you have anything to add? If there are no other questions, we're 1 minute over past our allowed time. Jazakallah, thank you very much for being patient with us, and I hope you learned something.
Good time, guys.
job.
You too.